the title is quite clear. Topography of the thorax already prepared, like that, and we could start directly with our topics. So first of all, we know that the thorax consists of the. So we will not describe everything, just some notes. Number one, or A, would be the thoracic wall, already explained on Monday lecture. So just to know that we describe usually thoracic wall, including B, the orientation lines on thorax, lines on thorax. That means we use some lines important for the description, like the median, sternal, parasternal, medioclavicular, etc. Then we'll follow the chapter, the projection of pleura and lungs on the thoracic wall, correct. Then the next point would be the mediastinum, plural, because mediastinum is only one. And then all the organs which are placed in the mediastinum. So this is the just a list of the topics which should be explained today. Concerning the number one, thoracic wall, we remember that thoracic wall is the consists of the ribs and the intercostal spaces and intercostal muscles. The muscles are 3 in number. This is just a revision. It's not necessary to do anything in the written version, because we know that we already discussed it in the one of the first lectures describing the muscles. So there is the group of the external intercostal, the internal intercostal and intimae, and then we know that they are classified as the inspiratory and the last two as the expiratory muscles. And then also we remember there is a neurovascular bundle situated just beneath the previous rib and not on the following rib, which is important for the exact knowledge where we can place the needle for the puncture of this intercostal space. No, fine. So this is not necessary. Starting immediately with the orientation lines. We know some of them. For instance, the most common and frequently used was the medioclavicular, for instance. So I mean that we can just draw very simple diagram starting with the jugular notch. Then we have the sternum, like that. I mean, would be sufficient xiphoidoxiphoid process. Then position of the clavicle, and then what else? The lateral wall of the thorax, like that. Here we are just sketching the that's it. And then here is the medioclavicular, must be a little bit lower position of the nipple, like that. The medioclavicular line will be that one. This will be median. Then this will be parasternal. I will use different colors. Then it will be the sternal parasternal. Then the anterior axillary. Then middle axillary. I don't have places because this is inside, and posterior will be drawn. Okay, so what could be colored in yellow as usually the bony parts. The bony parts as we see it. Here is the xiphoid process done. Concerning the lines, we start with the first one. I will use letters or numbers, will be even better. Number 1 and arrow. Number 2 would be which color? Blue. Why not blue? Will be that one. Passing on the side of the sternum would be number 2. Then number 3 would be what? Interrupted line. What do you think? Interrupted. Yes. Also interrupted arrow number 3. The colors could correspond in the lines could correspond with the numbers. Why not? Then medioclavicular must be very clear orange color, good one like that one, and this is number 4. Then number 5 must be axillaris. Axillaris could be that one, anterior axillary line, good, number 5. And number 6, harder to see because it lies at the center of the arm. No, practically in the tip of the axilla. So could be black. Number 6. Number 7 could be also black because this is the posterior. Anterior, no, must be middle. 5 would be anterior, 6 is the medial, then posterior, and then number 8 would be scapular, so it could be on the back side. Then 9 is the paravertebral, would be also on that side but shorter, and number 10 is in fact the same as 1 from the back side. Good. So the names. Number 1, as you see, is called median. We could use both words, linea mediana or anterior, linea mediana anterior. Why not? Median anterior line passing through the midpoint of the or median plane. Good. Number 2 is the sternal or sternalis. Linea sternalis. That word linea will not be repeated. Sternalis. Number 3 is the parasternalis because it lies parasternalis sternalis in the midpoint between, or lies in the mid of the distance between the medioclavicular following and the previous one, number 2. So this one is, I will use the same color because it's very important. Medioclavicular. This is possible to use clavicular. Not completed. Medioclavicular. Clavicular. Linea medioclavicular. Medioclavicular easy. Number 5 is the anterior axillary. Axillary passing through the anterior boundary. So we know that this must be the pectoral muscles. So passing through pectoral muscles, anterior. So I would say pectoral through the pectoral pectoral and pectoral muscles. Correct. Number 6 is the same, but the middle axillary. So passing through the tip of axilla. Number 7 is the posterior axillary. Posterior axillary. Posterior axillary passes through the thoracodorsal muscle, forming the posterior boundary. And then number 8 is scapular. Yes, scapular, easy to remember because scapular passes through the inferior. We can add specification inferior angle of scapula, passing through inferior angle of scapula. Done. Number 9 is the paravertebral, paravertebral, which is that one. No, paravertebral passes, maybe we need one more word. Paravertebral is the passes through the tips of transverse processes of vertebrae. This is sufficient. And number 10 is the median. So we said linea mediana anterior. I'm repeating a Latin word, linea mediana posterior. We can use all the English words, median, anterior median line, sternal, parasternal, and so on. So this is easy. No, and since we have this drawing, and I mean that is not bad if we if we can also specify the areas, the regions. We will not describe regions, of course not, because this is in fact not necessarily describe the infraclavicular region, etc. But just to know the names, why not? So I would mention which color. We could use a different color. Maybe this red is different. We could say regions, just names, and the regions means the first one will be A. Why not? This is sternal. A sternal. B would be infraclavicular. This that one. C is the clavipectoral. D is the mammary. And E, why not? E is the hypochondriac. Good. So the names. The first, okay, so B, C, D, E. All the names will be in the same row. A is the sternal region. Then infra, B is infraclavicular. C is the clavipectoral. D is the mammary with mammary gland, etc. Everything was explained. And E is the hypochondriac. Hypochondriac. That means below the diaphragm. So I mean that this is absolutely sufficient. Then we have to speak about the projection of the position of the pleura, that means parietal pleura, and visceral pleura, that means lung, on the anterior wall, or not anterior and posterior, better is to say on walls, because on both. So the title would be projection of pleura and lung or lungs on the wall, logically thoracic wall. No, we could say that this is quite logical. We need just simple sketching. If you look at the lung, so drawing just lung, right? Lung, not a big diagram, that one. We need what we need. We need the opening, the hilum hilus. So here would be the hilus. Then we see the trachea dividing, and of course into the main bronchi. This trachea like that. It must be different angle like that and that one. Okay, and here you see trachea, no need to draw more. And then also the lung is slightly oblique, like that. And lung is covered by the visceral pleura, drawing the visceral, that means the outline of the lung, and the reflection close to hilus. Then using blue, drawing the parietal pleura, which is different. We look at the difference in the position. Also here is the space. The same will be on the opposite side. And then, of course, there is the wall with the ribs, etc., etc. Everything is quite clear. And here is the diaphragm, right? So this is what we remember. This area, of course, is called hilus or hilum. The pleura, repeating the colors, pleura is the, in blue is the parietal, and in red, visceral. So parietal, and that one is visceral, correct. This is the same as the surfaces of the lungs. If we see that the space between you see the pleurae, both of them follow each other in some parts, in the other ones not. Some spaces which are formed here are deeper or shallower, and we speak about the recesses. This will be explained. That one is the costo, I would say, recess, and that one is the this one is called the medial one, the medial, which is in fact the costo mediastinal must be. Speaking today, this morning, 6 hours. That means not so quick. Costo mediastinal, costo mediastinal recess, and costo diaphragmatic. Costo diaphragmatic. So there are two recesses, costo mediastinal, costo diaphragmatic. This is the deepest one, deep one. We will speak about that later. But concerning the pleura, repeating, parietal visceral, correct. So these recesses can contain the fluid produced by the pleura, but it is can contain also the pus, blood. So that one, especially that one, is of high clinical importance. We would say that that one can, because this is much shallow, I would say just shallow, right? This is shallow. Can contain, that one can contain large amount, we could say large amount of fluid, of pleural fluid. Normally the size, the cavity, the distance between pleura, parietal and visceral is around 1 to 2 millimeters. So this is this could be not that big, but in some cases, in the inflammatory diseases, etc., either this could contain pleural fluid, or it could contain also blood or pus, and all these facts are important or are of high clinical importance in diagnosis. So we could say in RTG radiograph, in radiograph, the recess, we could say disappears, right? So we normally don't see anything, because normally it's empty, dark, but then it's white, this appears, and this is important for diagnosis, for diagnostic data. So I mean that this is absolutely clear, we don't need more. The one more thing is that not bad would be to see one superior view, one diagram, which shows just the section, I would say section through the pleural cavities, better horizontal section through the pleural cavity or cavities. Just sketch. If we repeating the same colors, using blue for the parietal pleura and red for the visceral, they practically follow each other. So then the pleura, as you see, has the following parts. Just repeating. Number 1, or A, could be a costal, right? This is costal. A is costal, yes. Costal. B is the mediastinal. We are at the level of mediastinal, so the mediastinal. And finally C, which is diaphragmatic. I don't see, because we are on the section, so below that is C, diaphragmatic. Just to know that there is a terminology diaphragmatic terminology of the pleura. That's it. So I mean that this is absolutely sufficient. So this was one thing, projection to the wall, and then starting with simple diagram projection. What we need? We need two lines anteriorly, posteriorly. Yes, we are looking anterior, posteriorly, dividing into the columns. Here we could use the lines, maybe that this would be more than sufficient, and we are just sketching. First of all, we are looking on the lines from on front. So here is the apex and cupula. So just sketching to the second rib, fourth rib, and then dividing. So this is the lung, left one. We are looking at the right one. The symmetry must be symmetry. That's important to know. Symmetry, correct. Anteriorly, posteriorly, good. And then improving the dimensions, because we know that this is the cupula of pleura. Then from to second to fourth, then diverging from the median plane, running like that. So and so. This is on the right side. So we could say that again, we are looking from on front, no, front on the one side only. That anteriorly, no need to add anything, because if this is anterior, then this is the logically that one is the right one, is the left one, right? Okay, and then look, concerning the red line, the cupula and the apex are the same. Maybe that we need also rib number 6. Must be here, and this will be rib number 6. And then following rib number 6, descending, then there is a difference running up, and then following again the median side. So median boundary. There is also rib number 4. So to the 6 distance of also oblique line. This is the horizontal transverse. So if we said that this is rib number 6, this is rib number 4. The same must be on the opposite side. So again, from the side would be the rib number 6. Left one copies the same. So starting with the blue, starting with the pleura, there is diversion from the right one, because there is the impression, a cardiac impression, deeper, also reflected by the pleura parietalis, like in our drawing. Then there is the apex descending, following, as we said, and then diverging again, reflecting the cardiac impression. Laterally is the same. And then look here at this level, we see, this is like that, we see the principal difference. And again, here would be the same. This is rib number 6. So we are at the level of number 6. And then the horizontal line is not present. So that one is the oblique line, oblique fissure, and that one is also oblique, and this one is the horizontal fissure, descending from T3. Well, we will see it on the dorsal view. So this is anterior situation, anterior side. By the way, the bluish tip is called cupula of pleura, but the reddish one is tip, is apex, right? So there's a different terminology. Fine. So I mean that this is quite clear. Projection. So because there is no place, I will summarize it below. Projection. What we see, hilus, because this is hilus here, hilus, hilum. The third intercostal space anteriorly, but T5 to T7 posteriorly, correct. Then pleura, parietal pleura, tal pleura, projection of parietal pleura, just parietal pleura, correct, and must be underlined by blue, is seen in the moment. Medioclavicular must be number 6. This is medioclavicular. That one is also medioclavicular. We can add medioclavicular line. No, we use the medioclavicular line on the line. So we could say medioclavicular is rib number 6. 6, no, opposite. I will just put rib, capital letters, and then rib, and then the number 6. Then anterior axillary is rib number 7. No, it's no, medioclavicular. Sorry, mistake. Must be one more, because this is 6, but medioclavicular is 7, so must be 7. Medioclavicular must be 7, so here must be a little bit higher. That one is like that, so this is 7. Medioclavicular must be 7. Okay, anterior axillary, just sketch. Anterior axillary is number 8. Then mid axillary is number 9. Posterior axillary is number 10, and maybe scapular is sufficient. Scapular is number 11. So these are the projection of the ribs, and then we see also areas. Area is the space between the pleuri, using yellow coloring the superior and inferior space. Superior S, inferior I. Superior is called interpleural superior, also called thymic. This was thymic area, older name, but more effective, more clear. And inferior is the same as inferior, interpleural space area, called also pericardiac area. That's it. So we see also topographically important areas, no? And the same will be from behind. So what we need is the posterior view. This is easier. So drawing the medial wall would be the same. So just sketch another one. Yes. So and then bluish, larger area, like in our drawing, and then reddish is in fact the same look, but in higher position, difference usually 1.5 vertebra or 2 vertebrae. Good. And then also the here must be T3. We are at the level of T3, and then descending oblique line. That's it. No. So this one is again oblique line. And here we are level of T10, this one T12, no? Or we could say that this could be at the level of 10th to 11th rib. No good. So this is the projection. situation with the projection of the pleura, visceral parietal, to the anterior and posterior wall. Important for what? Important for exact description of any event in the lungs, in the cavities are used by the ENT, so otolaryngology, so physiology, not otolaryngology, no, physiology. That means pulmonary diseases, the discipline dealing with the pulmonary diseases. I'm sure, I'm 100% sure that this is quite clear. Recess, pleural recesses, pleural, we have drawn pleural recesses, but we have to draw or say some words to the pleural recesses quickly. Maybe that recesses are repeating. First was the costodiaphragmatic. We already mentioned, I will not mention anything else. Costodiaphragmatic, the deepest one. Number two is the costomediastinal. This is shallower, and the last one is retroesophageal. Because this was on the, this should be drawn on the horizontal section. Retroesophageal on the right side. It lies behind the esophagus. You see, behind esophagus. That's it. So I mean that we already said that pleural recesses are important for the diagnosis of some inflammatory diseases. So for the practical medicine, for the physiology and so on, as we said. Okay, this is sufficient. I'm sure that we don't need anything else. Next topic is the mediastinum. Mediastinum is complicated space, complex of the structures and organs is found there. So the title must be also big one. Mediastinum. Yes, mediastinum. The word mediastinum means standing in between, from Latin, in between. So mediastinum is the space between sternum, vertebrae, thoracic vertebrae, logically, then vertebrae, then pleural cavities, right? So these are boundary. Of course, there is also superior thoracic aperture and inferior thoracic aperture. So I mean that we have to try to explain the two approaches to draw the mediastinum. So I would say, based on the typical anatomy, in anatomy used the classification. This is like classical anatomical. So I try to start with a drawing, because we have to start with a simplified version, not with complicated. You are in the first year, and there are so many information. This is not easy to keep everything in mind. Here we have number one, vertebrae number one, number two, number three, number four. 4 is that one. 5, 6, 7, 8, 9. 5, 6, 7, 8, 9. Yes. 10, 11, 12. So we need this vertebrae. Then what we need is to draw the superior aperture, drawing the sternum. We know this manubrium of sternum. Then the body of sternum, and xiphoid process must be approximately too long, must be shorter a little bit. So this like that, manubrium, of sternum, then manubriosternal joint, and that must be a little bit shorter because the xiphoid process must pass through the intervertebral disc 9-10. No, xiphoid process could be colored by blue. The bones without any, and also drawing the diaphragm, which is finally attached to the sternum and also to the last vertebra. Fine, could be colored by red, with exception of the central tendon. You remember that we have the central tendon yellow, green. No, there is the line, but there is not that good. I have to leave it. I will just even shorter the line because the aperture is must be much shorter. So we need the line passing through, and now is much better. Correct. Yes. Here's the manubriosternal joint. I would say manubrio sternal joint. This is in fact through joint, which can fuse together. I mean, manubrium and body of sternum can fuse together, and this can be fully ossified. But in fact, there is a small prominence, and through this manubriosternal joint and intervertebral disc number 4-5 passes imaginary line. Imaginary. We know that this is imaginary line because it helps to divide the whole mediastinum into some areas. First of all, here is the moment. We have to mention also superior thoracic aperture, apertura thoracis superior aperture, or inlet, thoracic inlet. No, bounded simply by sternum. It's easy. Sternum. What else? Rib 1 first. Rib number 1. And T1 vertebra. No, this is easy. And then superior aperture could be underlined by green, for instance. Superior thoracic aperture, that one in green. Inferior aperture, inferior thoracic apertura aperture, or outlet, thoracic outlet, which is formed by the xiphoid process. Again, I will just put sternum, then vertebra 12, rib 12, but internally deep, I would say also the deep boundary is the diaphragm. Okay, diaphragm. So this is quite clear. We know the boundaries, diaphragm. Okay, boundaries, and then the mediastinum. So concerning the first one, we call it superior. This is superior mediastinum. That one up to here is the inferior, and inferior mediastinum, which lies below that imaginary line. Maybe that we can draw it using red for interrupted line. And the inferior mediastinum is divided by the position of pericardium. This is pericardium, as you see, with the anterior wall, with the posterior wall, and we could color it by light red. And this middle mediastinum contains the heart, so this is called medium, mediastinum medium. That one is anterius, mediastinum anterius, or anterior, of course, both, because Latin is anterius because it's neutrum, and that one is mediastinum posterius. posterius or posterior, both, logically. So again, the anterior mediastinum could be colored by yellow, medium by red, posterior, for instance, by light blue. Good. So we know the boundaries, we know the constants. So this is typical description of the classification of the subunits used in anatomy. This is more clear, more easy for understanding, better for the description, which has a better system. But respecting the fact that there is also another type, another approach, not type, there is type of the description, another, which is the description used in clinics. Clinicians, they describe or divide the mediastinum. I'm just sketching now because it's not necessary to draw carefully the diagram, just to see the main parts as we have. I'm not counting the vertebrae, must be absolutely the same, like that. So we see just what I'm drawing: superior aperture, inferiorly the diaphragm, that's it, and then the manubrium, sternum, vertebrae dorsally, posteriorly. The clinicians used now even more published papers, uses also the traditional classical description of the mediastina as in anatomy. But we have to mention that they divide it into the anterior, and posterior. They use just two, either anterior or posterior. And if we draw again the position, it could be shorter, position of the pericardium, as we did it, without any imaginary line, they, because we have to also draw or just sketch the position of the aorta. Look, here is the aorta. Aorta passes dorsally, descending in front of the vertebrae. So this is aorta, just light red, with arch of aorta and descending part, descending aorta, like that. Then in front of that, what color I need to, brown or violet, doesn't matter. So drawing also esophagus, look, here is the esophagus, also passing through and opening here, this is esophagus. And esophagus, in front of esophagus is the trachea. So drawing esophagus, like that, and in front of esophagus, trachea. Trachea divides at the level, it's like that, at the level of T4, because we are at the level of T4, must be T4, right? So divides into the right and left bronchus. So the classification using the way in clinics divides the whole mediastinum into two parts, using just a line passing through the trachea and posterior surface of mediastinum. Would you imagine? So the line separates, this is anterior, that one is posterior. So what lies in front of this line is the anterior mediastinum, what lies behind this line, posterior mediastinum. Difficult to describe it because the many structures pass through both, and then for students it's really complicated. Another classification is used for another line. That means the line may be different color, maybe not orange is not good. Maybe another blue, yes. Another line passing through the esophagus, through the posterior surface of esophagus, and then there is the second classification, you see there is no boundary, so this is difficult to say what is anterior. But according to that classification is the anterior, which would be yellowish, okay, yellowish. That means from the sternum to the anterior wall of the pericardium. Then that one is the middle mediastinum, middle up to the line, and then including the so middle, the mediastinum, and from here to the dorsal side is the posterior. So they are more unclarified things because it's difficult to describe the structures. But for any case, I would like to say now that for our description, we will use this standard approach describing mediastinum superior, inferior, and inferior, anterior, middle, posterior. Sometimes they say this is the inferior, anterior, inferior, medium, medium, and inferior, posterior, or mediastinum posteriors, anteriors, posteriors, or the other classification. That one is more complicated for description, although it respects the fact that the structures pass through continuously through different mediastina, so it has the logical base. But I mean that for you will be much more complicated. For in case, I will prepare for you just a simple drawing in which we will put exact boundaries and also the contents in each mediastinum. Sufficient, finished, done. So I mean that we can now go to the following text, which is important for us, and starting with the superior mediastinum. Superior, okay, superior. There are some structures which should be mentioned. Superior mediastinum. No, in superior mediastinum we see some structures. For instance, thymus must be discussed. Some of them are very easy. Structurally, the superior mediastinum could be described also in some rows. So organs, I would say organs are situated in rows. And we will see if it's true. What we need, we are trying to draw the inferior view, so which is important for description in clinics. So we will do the same, inferior view, anterior view, or inferior view, and then drawing first of all the sternum. This will be sternum, that behind sternum lies the thymus with some lymph nodes, para and retrosternal. Then follows the pleura, so drawing the pleura on both sides. There is no absolute symmetry, but because left is deeper, but doesn't matter. For any description, that one is the right side, this one is the left one. You see, very important just to revise it. For the pleura, I'm using green, so this green shows the pleura with the and that is the lung, definitely. You see, this is the lung. It's like that. And we need also vertebra. The section would be vertebra. The title could be the horizontal section at the level of T4. So I would label the vertebra as T4. So we are at the level of bifurcation of trachea, which lies at the level of T4. Correct. And that one. So bony structures must be again in yellow. Oh, this is too, the spine is too thick, and you will criticize me that I'm drawing so thick, too thick spine. That's good, that's better now. Okay. So the bones in yellow, sternum and vertebra. Okay. Then for the thymus, could be violet could be, because this is lymphoepithelial organ. Then light green for the lymph nodes, some of them, parasternal, retrosternal. Then the red for important artery and vein, which are called internal thoracic. Then we need the position of aorta. We know that we are at the level of the bifurcation of trachea, but we see the aortic arch, because I have to respect that there is aortic arch opening, like that. Then on the right side must be the superior vena cava. Then we need the trachea divided into two main bronchi, so maybe that this could be the best. It's like that, trachea. Then different color for esophagus. Esophagus is here. It's very dorsal, but at this level, because in the caudal direction, the aorta lies behind esophagus. So esophagus with typical lumen, also good. Okay, and then thoracic duct behind on the left side of the esophagus. Then prevertebral fascia with the duplicatures for the sympathetic trunks, black on this side. Then we need the hemizygous and azygous vein, azygous on the right, hemizygous on the left side. We need also the laryngeal recurrent nerves. Then we need also vagus. This is the right vagus, which lies here. Left vagus lies on the opposite side. This is that one. Then phrenic dexter, right phrenic, and left phrenic would be like that. No, and this is all. So don't forget to add that this one is the pleura, and logically lungs, right? Here would be on one side only, just sketching the tissue, the parenchyma of the lung, right? So here is the lung logically, because we know that it must be like that. Fine, and then description. Starting with the sternum, yes, this is anterior sternum. Then thymus, remnants of thymus. Internal thoracic artery plus vein, internal thoracic artery vein. So then parasternal, just few parasternal. Now there are many parasternal lymph nodes. Yes. Then that one is the right phrenic nerve descending to diaphragm. That one is right phrenic nerve. Yes. Then aortic arch, arcus of aorta. Then left vagus, then right vagus, In front of that, the blue one is the superior vena cava superior. Then the bifurcation of trachea into two main bronchi in the centralized carina. This one would be carina. Carina is also important for description of the air passages, especially in urgent situations. And then here we see the recurrent laryngeal nerve. laryngeal nerve. We know that laryngeal nerve lies between the trachea and esophagus. This is true, and ascends to larynx. Here is we are in the upper part, so this is accessory hemiazygos. So accessory hemiazygos vein. Its bigger sister is the azygos vein on the opposite side. Then here we need the thoracic duct. No place, thoracic duct. The biggest duct which is found, thoracic duct is found in the posterior part of the region, the area. Finally, the sympathetic trunk. So you see there are so many structures. Nice area, sympathetic trunk, truncus sympathicus, sympathetic trunk. No, fine. And we said we are at the level of T4, very important for orientation, because we know that at the level of T4, the trachea divides. There is also position of the aortic arch, where the aorta ascends into the superior and then goes back to the middle mediastinum. So I'm sure this is sufficient. And then we said that the organs are arranged in rows. No, it's true. When we look at the diagram, we can simply describe using some rules. This will not be bad. So drawing the structures in the antero-posterior direction from on front, and we could mention structures, organs, yes, and we could start directly. Some notes could be made on the right side of the column. So anteriorly, we see the internal thoracic arteries plus veins. This is true. They are situated anteriorly, just on sides. On sides of the sternum. This is correct. Then follows the parasternal nodes, lymph nodes, and immediately also the thymus or remnants, also remnants, yes, good. Then pericardio then are not drawn here, but they descend laterally on the pleura. So I would say on pericardium, pericardium descend, pericardiacophrenic, because they are branches of this internal thoracic, pericardiacophrenic, pericardiacophrenic arteries plus veins, correct? They descend together with the phrenic nerve. Then follows what? So I mean that it could be green arteries, veins. Why not? Arteries and veins. Then thymus, right? Thymus. Then pericardiacophrenic arteries and veins, correct? Then in blue there is the vena cava, so superior vena cava plus and brachiocephalic, because they form the superior vena cava, brachiocephalic. We are speaking about not only about the section but also about the whole space. Brachiocephalic veins, correct? Then must be phrenic nerves, phrenic nerves, and plus nervi vagi, 10th. Then follows the row of the arteries. This is the aortic arch plus branches of aorta, branches that branches. Then and plus pulmonary trunk, yes, practically the same row, and pulmonary arteries plus pulmonary arteries. And then follows, which color I used? Dark blue, trachea and bifurcation of trachea. So trachea, either bifurcation LVT4 or just trachea sufficient. Then immediately after that lies the plus recurrent laryngeal nerves, of course, laryngeal nerves, correct. Then follows the esophagus, definitely, esophagus. We can write also esophagus, plus behind that lies thoracic duct, the thoracic duct lies behind thoracic duct, fine. Then what else? Then azygos veins, azygos and hemiazygos, so we just put azygos plus hemiazygos, this accessory, but the whole hemiazygos, azygos veins, azygos and hemiazygos veins. Then finally, the deepest structures, look here, are situated the sympathetic trunks. No, this is true. We could sympathetic trunks. There is one rule that if we describe the structure of the superior mediastinum, not only at this section, and usually the nerves are situated between, you see, that's why I'm leaving here just space for yellow line, that the nerves, phrenic and vagi, plus the branches, they descend between the group of the veins and arteries, because the pulmonary artery is the same as the aortic arch. So again, the nerves are situated between the row of arteries and veins. So I mean that this is very good and very clear. One structure should be mentioned specifically, because this is the thymus. Thymus is really a special organ. We cannot just say that this is the position of the organ. Concerning the other structures are quite clear. Arteries, logical, and then phrenic arteries and veins, pericardiocophrenic, and then superior vena cava, nerves, aortic arch, and so on. But the thymus needs some time. So looking now at the thymus, we can start immediately here, because which color? Maybe blue. Thymus as an organ, right, on the next page. And we could say that it lies on the same side in superior, lies in superior and also in anterior mediastinum. Fine. So we know the location, and then some words to the actions. The thymus is in fact organ of primary production of lymphocytes. So it has high activity as the organ producing lymphocytes in growing body. So we know the position that we have. Okay, we are here. This is the one of primary lymphatic organ. Lymphatic organs, one of primary lymphatic organs. This is one thing. This is consider the function and action. We could say that this is the growth, responsible for growth and differentiation of T lymphocytes. This is number one, lymphocytes. We call them also thymocytes. Thymocytes are called thymocytes, yes. And also, we could say that this is also the place or location of maturation, the worst of the lymphocytes. This is quite easy, quite logical. Then we know that we said that in the early stages of development is also the place of formation of the T lymphocytes. But normally, no, in the adult or in childhood, the lymphocytes are formed by bone marrow. So we could say the lifespan. Bone marrow is responsible for full production. So we say production of lymphocytes. They are transported of T lymphocytes. They are transported via blood vessels. Via blood vessels, blood vessels are transported to thymus. Thymus. Then, if they are finalized, fully matured, so then the matured lymphocytes are transported again via bloodstream, via blood to the secondary lymphatic organs. Do we know them? Yes. This is spleen, lymph nodes, tonsils, for instance, tonsils. So they are secondary. So starting with some nodes, lymphocytes, so maturation of the lymphocytes. Okay, bone marrow production, thymus, matured, transport via blood to the secondary lymphatic organ or organs. Yes. So I know concerning the type, the structure of the, or we could say structure of the thymus structure. It usually is bilobular, has two lobules, which could be around 4 to 6 centimeters high or long, and around 2.5 to 2.5 centimeters wide. Color preferably could be light orange, as we see. It has also its own capsules like in the sketch. Yes, capsule. And also there are many vessels that supply. Each lobe has cortex and medulla on the surface. Capsule. No hilus. So the vessels enter or pass into the organ on different sides. Vessels, yes. Arteries. There are more arteries. Number 1, number 2, and number 3. There could be usually 3 categories. 1, 2, 3. Look, the number 1 is the internal branches of internal thoracic artery, mainly thoracic artery. The second one from the inferior thyroid artery, which comes from the subclavian. Finally, the intercostal, some branches intercostal arteries. That's it. Concerning the veins, easy, because veins on the other side, they open into the inferior thyroid mainly, not thoracic that much, but in the intercostal, and also into the preferably left, into the left left brachiocephalic vein. No, interesting thing is that, of course, is visible on CT and magnetic resonance imaging. The organ could persist. Thymus can persist actively, in some cases actively to old age. Usually substituted or inferred. It contains, in the older age, it contains the fat, or the fat replaces, but fat replaces the lymphoid tissue. This is important fact. Lymphoid tissue, fine, good. Fatty tissue. What is typical for the thymus are the age-related changes, because the weight, we know the dimensions. The weight is usually up to maximum 30 grams maximum, because in the older age it could be much less, only few grams. So age-related. Why not to try to draw two lines to access, to show that years on the, there we see on this axis we could add 1, 2, 5, 14, 40, 60. No, why not? 15 grams, 30 grams, usually even not that much. At the beginning, in just after birth, it has around 15 grams. That it grows up to the whole puberty, and then after that starts regress, and finally never to zero, because we said that after, or based on the clinical examination, I mean the clinicians, endocrinologists, and so sometimes in old age the thymus is active. So we know that in this period of the regress, the thymus is infiltrated by the fatty tissue. So we know the size, dimensions, position. No, position. Position is behind the sternum. It's not that easy to say, because in some cases the thymus could be even longer. We know that thymus, just information, we remember thymus develops from branchial arches. You remember, from the handwriting must be improved, from the branchial pouches. You remember pouches number 3 and 4. So it means that in some cases, these two parts develop independently and even reaching the level of the thyroid gland in the neck and descending to the xiphoid process. But simply position or topography of the quickly. Also, maybe one sketch could be helpful. Trying to draw a manubrium of sternum, yes, body of sternum, correct. Xiphoid process. What lies? First of all, drawing two muscles, just one line, two muscles, and this is the sternohyoid, sternohyoid and sternothyroid, thyroid for better orientation on the sagittal. This is sagittal section, correct. And then here lies the thymus, usually in the neck area or also behind the sternum. That's normal size, using orange again. But in child could be much more. In child could be even that long, or even also in the thorax, into the neck, also to the thyroid gland. So in child, I would say in child, longer, because you see it develops from the third and fourth, from two different pouches. Fine. So anteriorly, what we see, there is the fascia. We know that this fascia is the fascia is called pretracheal. Repeating, it is the capsule, correct. Then behind that lies the brachiocephalic vein, also trachea, and also anterior part of the pericardium, especially in children. Pericardium could be a direct contact because it's longer. So here we have pericardium, here we see the brachiocephalic vein, right? And here is the trachea. So we know the anterior and posterior relations of the thymus as an organ. Laterally, of course, I would say laterally on sides are pleural cavities, logically. Fine. So I mean that, what else? One more. Arteries, veins, nerves. Quickly, nerves. Do we have place? Nerves. Why not? Nerves here. Sympathetic, and parasympathetic. Easy. Sympathetic trunk and parasympathetic 10 vagus. So underlining both because this is easy to remember. No? And lymphatics. No, lymphatics. Lymph is drained into the mainly, there are more groups, but simply some groups of mediastinal lymph nodes. Fine. So we know exactly everything about the thymus. No? Thymus, very good. And then what else? Then this was the superior mediastinum. Then follows the inferior mediastinum. We start directly with the anterior, either anterior, inferior, or just inferior, which is sufficient. So looking now at the in the anterior, this is very easy because anterior, I will show you diagrams. Anterior mediastinum. No, anterior mediastinum is just a cleft, in fact, narrow cleft between the sternum and the anterior wall of the pericardium. Before that, I would like to show you just some diagrams because this is also important. First of all, we are looking at the diagram showing the mediastina, that line, the imaginary line passing the oblique position of the diaphragm, we know superior, anterior, middle, posterior, as we said. Here is the projection of the heart. Then we see the diagram of the projection of the pleura and lungs on the anterior and posterior wall. This is what we said. Here we see the oblique fissure. Here is the oblique fissure, horizontal fissure, inferior boundary of the lung, inferior boundary of the pleura. Important for us would be some topographical views. Here look at the position and location of the thymus. It lies on the vessels, and lies also on the on the anterior side of pericardium. And then starting with the other mediastina, this is not anterior definitely, but this was the superior, as we said, and then posterior. But at the moment we can say that in the first row there is the pulmonary trunk divided into the pulmonary right and left pulmonary arteries. At the same level we see the arch of aorta with the main branches, the brachiocephalic trunk on the right side dividing into the common carotid and subclavian artery. These arteries are separated on the other side. Then we said that they are also the nerves. Number one is the vagus, which descends here and forms the recurrent laryngeal nerve, which ascends on the side of the trachea. The same is on the left side, but on the right side. But on that side we see the shorter recurrent because it goes or runs around, like forming a loop around the subclavian artery. Then look that dorsally there's the esophagus. Posterior to that is the aorta. Esophagus passes through the opening in the diaphragm. Here we see the hiatus, and here is the hiatus of the aorta. And then later we will see the mediastina. So this is the anterior. So practically very few structures are found. Maybe that better would be on this diagram. Again, we see the space here, anterior mediastinum. So just there are some ligaments. We call them pericardiac or phrenic and sternopericardiac. Then branches of the internal thoracic artery. It doesn't need that much. Maybe just the contents. Boundaries we said. Contents the branches of the arteria thoracica interna plus veins. Logically they run together. This is one thing. Contents, yes. Then parasternal lymph nodes, parasternal lymph nodes, yes. Then sternopericardiac ligaments. No, it's easy. Sternopericardiac ligaments stabilize are important for stabilization of the pericardium to sternum. This is easy. There is nothing specific. No, this is anterior, easy to remember. Then using medium pericardium, medial medium pericardium, medium pericardium. Yes, so medium P pericardium, medium is better, no, doesn't matter. The medium is also easy because concerning the contents, we would say that medium contains the heart, no? Plus here we have medium, and then moment. This is from our book concerning the traumatology of the thorax. If we look at the middle mediastinum. We see of course, this is posterior. This is not middle. Up to here is this is just anterior, as you see. Here we see the internal thoracic artery and vein. Here is the rest of thymus. Here's the posterior mediastinum. So from here is the posterior. And then medium contains the heart with pericardium. And then the pericardiocophrenic vessels that descend on the surface of the pericardium and also together with the nerve. So pericardiocophrenic vessels plus phrenic nerve. So really easy to remember contents. So we would start with the pericardium, pericardial vac, the sac pericardium plus heart, of course. Then vessels, superior vena cava must be. Then origin of aorta, because also aorta must be there. Pericardium, superior, pulmonary trunk, aorta, of course, aorta plus pulmonary trunk. Then also pericardiocophrenic, pericardiacophrenic arteries plus veins, and the phrenic nerve. They run on sides, phrenic nerves on both sides. No? So I mean that this is really easy. We don't need anything extra to describe the pericardium, etc., etc. This is not necessary. Looking again at the on this pericardium, this is the anterior wall, posterior wall. Here we see you see the origin of the aorta. It lies on the surface. Then here we see the left pulmonary artery. Then here we see the pulmonary veins, and this is the main bronchus. There is difference between the right and left side of the hilus. Looking at the hilus, maybe that is quite easy. We are looking now at the left mediastinal surface of the lung. You see everything in the atlas. It is easy. Here we see the phrenic nerve, location of the phrenic nerve. It doesn't form any depression, but here is the vagus. And then, as you see, there is the hilum hilus with pulmonary ligament, and the position of the main structures in the craniocaudal order is on the left side is the A artery, B bronchi, and C the vein. It could be two veins, pulmonary vein. So this is the ABV, but on the right side is the opposite. B bronchus, the most cranial, BAC, BAV, sorry, not C, C, V as the veins. You see, and again, this is the same when we look at the left hilus, ABV, the opposite, the right one, BAV. Fine. So we see the difference, and here on the side you see the phrenic nerve in yellow, and artery and veins, arteries and veins, the pericardiocophrenic, sufficient. So, and then we approach to the posterior mediastinum, which is relatively complicated, posterior, because there are some structures that extend from the neck and end at the level of the T11, T12, posterior mediastinum. Posterior mediastinum is bounded anteriorly by the posterior wall of the pericardium. So posterior boundary is not bad to repeat. Posterior wall of fibrous pericardium, because this is the external one, fibrous pericardium, because the cirrus is inside, pericardium, then vertebrae, boundary one, vertebrae, yes, T5 to T12, and laterally they are pleural cavities, pleury, why not pleury? Fine, this is the boundary, and concerning contents, and then we have to say some words to some structures. It will take some time. That means vessels on the dorsal side, the nerves, sympathetic trunks, the thoracic duct, and also the esophagus, which is the most complicated structure in this area. So just names and facts. So pulmonary veins, logically opening into the heart. Then esophagus. We said esophagus, long structure. Then nervi vagi, vagi nerves, plus, or we could say just plexus, because they form the esophageal plexus. And note that if we see the esophagus, here we have the anterior surface, this is posterior, then that one is the left, for instance, sufficient. So if we look at the esophagus from above, posterior above, also from above, you can draw also from below, doesn't matter, from above. So then right vagus lies on the posterior side, left vagus, the right goes posteriorly, left goes anteriorly, and they send the branches forming the plexus. You see, so here again there are two vagi, posterior vagus, this is the right vagus posteriorly, and here is the left vagus, just to know that they change the position in the descending here, definitely. Then thoracic duct lies in the area. Then of course the aorta, descending aorta. This is the most dorsal. Then thoracic duct, we said, aorta, azygos vein, azygos plus hemi, of course, azygos vein. What else? Then sympathetic trunks. So we have everything. No? Yeah, I mean that we have forgotten anything. No, and then we are looking at the posterior side. No, maybe that we can draw it here. Why not? Drawing the right brachiocephalic, vena cava, left brachiocephalic. No, must be changed a little bit more to the left, because we need both sides. Okay, this is not problem. 1, 2, brachiocephalic, right, left, vena cava, 1, 2, 1, 2. Correct. They are the sinuses, but doesn't matter. This is okay. Here we see the interjugular vein, and here's the subclavian correct position. The vessels could be colored by very light blue, because we need also another blue for the azygos system. Correct. Here I'm just drawing as a projection the opening of the azygos vein, drawing now the azygos vein, which ascends maybe that in order to reduce the length of the drawing, otherwise we would need much more. So this is azygos. I would just put azygos vein, correct. And then, of course, azygos vein receiving blood from intercostal spaces. Everything is quite clear. The same on the opposite side. but there are some interconnection. Better is not to draw any, because better would be to start to draw the accessory hemiazygos, which is thinner, collecting also blood from here, descending, cut. Usually it goes to the opposite side, opening into the azygos, right? Inferiorly here, usually here, we have hemiazygos, which has also the segmental veins. So we said that we need a different blue, correct? So in different dark blue, we see the azygos system, or system of azygos veins. That means hemiazygos, accessory, and hemiazygos. So this would be absolutely sufficient. There are some irregular interconnections. The first one is usually lies at the level of around 6, not usually 8 to 10 vertebra. So usually at this level, T8, T9, T8 to T9, usually the we call it accessory hemiazygos vein opens into the azygos. Hemiazygos below that can open into azygos either close to the previous interconnection or even in the other. So it could be like that or it could be like that, doesn't matter. Hemiazygos, there are so many varieties, so many variants. Concerning the position of another important structure is the this is the duct, the thoracic duct. By the way, we have to mention that we are at the level of T4, right? At the level of T4, the azygos opens into. There are also the superior intercostal. The other ones, no need to see all of them. What I mean that the thoracic duct crossing the veins ascends on the right side of the right margin of the aorta, that it goes up still on the right side. Then at the level of the T4 usually changes the position, of course receiving also segmental tributaries, goes up, ascends behind the brachiocephalic vein, crossing it, dorsally also the internal jugular vein, and finally opening into the left venous angle. Using green, there are some segmental smaller trunks. So then this thoracic duct opens into the, we could name it, this is called left venous angle. This thoracic duct is long, situated in retroperitoneal space in abdominal cavity, but here lies in the posterior mediastinum, and it opens into the left venous angle and drains 3/4 of the body. 1/4 of the body is drained into very short, around 1 centimeter long, right lymphatic trunk or duct. Now it must be improved. Angle, trunk or duct, And this duct drains only right half of the head, right half of the neck, right lung, and right upper extremity. And then, just to be sure that we understand, this duct or this trunk receive 3 other trunks. I'm drawing just three lines like that, and they are same on both sides, having the numbers 1, 2, 3, and 1, 2, 3 are like tributaries, are the trunks, and we call the number 1 is jugular, collecting lymph from the head and neck. Now number 2 is the subclavian, like subclavian artery and vein. Last one, bronchomediastinal, mediastinal. So we know that these trunks can also open directly into the veins, not only into the thoracic duct or to the right lymphatic trunk. Doesn't matter. This is quite easy. Now fine. And the last structure must be mentioned on both sides of the vertebral column. Run the sympathetic trunks, just sketching sympathetic trunks. We remember that the sympathetic trunk consists of the ganglia interconnected by interganglionar tracts, and so on. It goes from here, right. It lies behind. Not in its mistake. Not mistake, just we have to be careful when we draw something, it lies behind. Yes, and this we call it just, these are interrupted line like that, and we call it ganglia of sympathetic trunk, and it contains around 10 or 11 ganglia thoracica. So there are 10 to 11 thoracic ganglia. So that's it. So I mean that we know the posterior mediastinum, we know the contents. We have mentioned also the the consequences. That means the position of the structures, and what we have to complete in the last not minutes only, in the last part of our lecture, is the esophagus, because esophagus is long organ, complicated in position, so we need some minutes to explain the position and course of the esophagus. So this will be the last topic for today. So looking now at esophagus. Esophagus is the tube, muscular tube, esophagus, and complicated in its course because, as we said, it descends from the position of C6 to T11 approximately. So quickly, is the muscular tube, muscular tube, which is around approximately 23 to 28 centimeters long, transverse diameter 1.5 to 1.8 centimeters. The thickness of the wall has 3 to 4 millimeters. So this is relatively thick, 3 to 4 millimeters. When we look at the position and course of the esophagus, we can distinguish between cervical, thoracic, and abdominal part, and we have to start here. We have to mention that we are at the level of C6, starting from C6, and then first part would be short, relatively short, is called cervical, pars cervicalis, cervicalis is usually 6 centimeters long and descends from the C6 to sternum, right? To sternum. Then sternum, yellow. Then follows the second part, which is called thoracic, pars thoracica, which is much longer, 16 to 18 centimeters. So it will be like that, maybe here. We are at the end, and we are at the level of diaphragm, right? So diaphragm, superior surface of diaphragm, and the last one passing through diaphragm into the abdominal opening is called, there's no place, so we call it abdominal, very short abdominal part, which is usually 1 to 2 centimeters long. So we have 3 parts, 3 portions. Descending from C6, and we have to add also that if we are at the level of the end, so at the end, that means usually T11. T11 is the end. So from C6 to T11 is the course, or we can describe the course of the esophagus. Fine. No, from this C6 to T11, and the esophagus has 3 regular physiological physiological constrictions. 3 physiological constrictions. So first one, I would use blue. The first one is at the level of cartilage, cricoid cartilage. So the first one is called cartilaginous, or the cricoid. We call it first constriction, lies at the level of C6. I would say constriction, and first one is the cricoid constriction. It lies at the level of C6, and in fact lies at the level of behind. It lies behind the cricoid cartilage. So that's why we call it cricoid constriction. The second one, so this is constriction like that, descending, and then we are at the level of approximately T4, right, where in front lies the trachea, dividing into right and left bronchus. So at this level, be like that. So at the level of the bifurcation is called sometimes they use the word aortic, because this is at the same side where the of course aorta lies in front, and then the left bronchus crosses the esophagus, and it lies at the level of T4. Aortic, where we would say where the left main bronchus crosses, where the main bronchus on the left side crosses the esophagus. It needed more text. Fine. Good. So this is the second one. The last one is simply called diaphragmatic, diaphragmatic, no, fine. Doesn't matter, this is here. Diaphragmatic lies at the level T10. That means where it passes through diaphragm. It doesn't need anything extra. So 1, 2, 3. There are 3 constrictions. The constrictions are important for one fact. Any damage, any damage, any violence, any wound, mechanical, iatrogenic, that means in placing of probe inside. So any wound and any aggressive chemicals like acids, you see, also acids can destroy the mucosa. Then healing is much more complicated in the narrow portion. So any wound, and also acids can narrow the esophagus in healing. So because healing means that mucosa needs more space. So any wound, any damage, any destruction by very aggressive chemicals, they can all these factors can narrow the lumen of the esophagus, especially in the prepared or places where the esophagus is narrow. Fine. Concerning the wall of the pharynx, number 1 is mucosa. Mucosa forms folds. Mucosa forms folds. Second one is submucosa. Submucosa is relatively thick, and because it's thick, so gives the space for formation of the folds, longitudinal folds. Then submucosa also contains the plexus plus, we could say, postmucosa, and the nervous submucosal plexus. Yes. And then number 3 is the muscularis. Muscularis is the wall which consists of 2 layers: window, longitudinal external, transverse circular. So external is longitudinal, as we see, and internal is circular. Circular is relatively strong, important for the passage of the food. Muscularis 2 layers we see, and also plus the myenteric nervous plexus. Fine. Plexus. Good. Then the nervous is definitely mainly vagus. Concerning the last one is adventitia. The last layer, number 4, is adventitia. Number 4 is the adventitia. Yes, adventitia. We know that. We will draw a diagram. Concerning the musculature, it in the superior, or better upper part, in upper 1/3 is striated, skeletal, striated. In the central, in the second third, is striated as we said, and smooth, both and smooth. And finally, in the lowest, in lower 1/3 is only smooth. Consider the passage of the food is under control by cranial nerve number 10, mainly vagus, including the myenteric and myenteric plexus, myenteric plexus or nervous plexus, myenteric. The passage is relatively quick, approximately 2 to 4 centimeters per second, right, per second. Concerning the musculature is also complicated concerning the composition. We know that the esophagus, because the tube should avoid any reflux, any return, any regurgitation of the food from the stomach. So it has two sphincters. Yes, two sphincters. One is called upper. It's called upper, but in fact it's upper esophageal. Esophageal. We can use this official term esophageal because this is a proper sphincter. Or we can say this is true sphincter. It exists because there are specialized fibers, and true sphincter is formed by the following structures. By the we will continue on next page. Number one, muscle fibers that originate from or simply of inferior pharyngeal constrictor, inferior pharyngeal constrictor. This is very clear. Constrictor. Then this is one thing. Is formed by number one, by number two, by circular fibers, the internal fibers, the layer. This is the circular layer, as we said. And number three, also submucosal, by the submucosal venous plexus. All three factors influence and form the superior or upper constrictor. B, using red, B is the lower sphincter, but in fact it's not sphincter because it doesn't contain any specific muscular fibers, but is the we could say lower sphincter lays at the level of the or better inferior esophago. Official term is esophagogastric junction. That's correct. Esophagogastric junction. This is not true sphincter. It's not the true sphincter, as we said, because it doesn't contain the specific fibers. But closure of this junction, closure is achieved functionally functionally by the following mechanisms, by the, again, number one, they are, no, maybe that we can, okay, see figure, why we mention of them, if we will be able to draw the diagram, the figure, and this will be the best. We are looking from the dorsal side, so this will be posterior view, posterior view, and then drawing the sphincter, then the esophagus, anteriorly part. This is from one Time book. So here we have the inferior horn, superior horn of the thyroid. Then we need the cricoid cartilage, correct? And then following are the cartilages of trachea. No? Good. So light blue for the both cartilages and not that much for the tracheal. Then at the center lies the raphe of the pharynx, and then drawing the fibers that run obliquely, right? Then to the cricoid cartilage run dorsally, obliquely, the fibers, which are called, we call them simply crico. Yeah, we call them cricopharyngeal sphincter or cricopharyngeal muscle. Cricopharyngeal. We call it this one or that one. Fibers of the cricopharyngeus, pharyngeus. So this is in fact the sphincter. This is sphincter, but not the sphincter of the esophagus, right? This is still pharyngeal sphincter. Then there are more fibers, but this is the most important. We will not draw all details. This is one thing. Then follows the zone, which is horizontal and forms the end of the pharyngeal sphincter, and then follows the transitional zone like that. Here you see the longitudinal fibers, and then here you see the circular, like a mix, circular and vertical, using red on this lower margin. Here we see the longitudinal fibers. Then this is more circular. We call it the circular muscle fibers. Circular muscle. We said it's strong muscle fibers. Circular muscle fibers with sparse longitudinal, because some of them are also longitudinal. It's like a transitional zone, longitudinal fibers, and we call it V-shaped or V-shaped area. This is in fact transitional V-shaped area. Fine. No, and then there are also some accessory fibers. They run on sides. We call it simply accessory fibers. No? So this is the inferior sphincter, accessory fibers from the posterolateral part of a cricoid cartilage. So this is what we see there. So there is the inferior sphincter. Good. And then there is one specific, very specific situation. We are looking into the esophagus descending Look, I'm drawing vertical axis of the descending esophagus. So here is the esophagus. Then looking at the diaphragm and stomach with fundus body. Here's the fundus of stomach. Stomach, yes. Then here we have the diaphragm, but diaphragm is not firmly attached to the by its own muscular system. There are some fibers, not so many. And look that here we see the vertical, and that one is the obliquely passing. So when we look at these two lines, one copying the direction of the position of the esophagus, as you see, and that one running parallel to the fundus. So this angle, as you could see it, is called the angle of Hiss's angle, right? Angle of Hiss. This angle of Hiss is also important, acting as the supporting mechanism for the closure of the junction. So here we have the diaphragm, correct, diaphragm. Diaphragm is attached to the esophagus by some ligaments. We call them, maybe here's the place, we call it the phrenicoesophageal, phrenicoesophageal ligament on both sides, phrenicoesophageal. Then there is also accumulation of some fatty tissue in close proximity to the wall of the esophagus. We call it, maybe here is place, we call it, or it's called the fatty tissue, is called fatty tissue, which lies under the hiatus, under hiatus, or under esophageal hiatus, correct. Then there is the plexus. We call it submucosal venous plexus, which is also relatively strong. So we could add one dot submucosal venous plexus. No, what else? Yes, and then there are some not only circular, but there are also some obliquely passing muscular fibers. We could add again the title. We call it spiral fibers. No, and what else? No, I mean that it could be all spiral fibers. So there are some mechanisms that help, and also we could add what we need. Yeah, there are mechanisms. Closure is achieved functionally by the factors, and the factors will be these ones. So I'm labeling them. Angle of His number 1. Fatty tissue number 2, ligaments, yes, number 3, venous plexus number 4, spiral fibers number 5. So why not? There are so many structures, so many factors situated in the lower. That one is superior. This is quite clear, but inferior is different. One more thing is that there is also specific situation that we look into the mucosa. There is Z zone, transitional zone between the mucosa of esophagus and typical mucosa of stomach. The mucosa of esophagus is lighter. This is in fact this is the squamous epithelium. epithelium, typical for esophagus, and that one is darker epithelium, which is columnar. One layer, more layers, and this is columnar. So there is different epithelium, epithelium, and this epithelium or the zone epithelium is important place for many defects. Even the carcinomas can appear. So I would say possible place weak. There's a weak point. I would say defects or epithelial. Maybe better to say weak point for epithelial defects, right? Defects, epithelial defects. Fine. No. And what else? So we know everything concerning the sphincters, the wall, size, length, etc. So just some information concerning the veins and arteries. So we could start with the nerves, because there is not sufficient place for it, and then we go to the end. Nerves are preferably from vagus, so mainly vagus, and also sympathetic, because they must be in balanced version. Arteries and veins would be explained. Lymphatic drainage could be for lymphatic drainage we can draw simply the esophagus, like in previous case, like that. So the drainage, lymphatic drainage, first of all, cranially in the central part, many ways, and also because we are in gaster, logically, in gaster, so also into the gastric area, repeating the darker colors, right? Correct. And so, well, so drainage to the cervical, deep cervical lymph nodes, logically. Then paratracheal, of course, because it's close proximity, paratracheal, then tracheobronchial, bronchial, yes, and then finally posterior mediastinal, my mistake, yes, you see everything, and then finally to the gastric, because the lower part is connected with the gastrus, so gastric, lymph nodes, and phrenic, no? And then on the last page, just information concerning the blood supply. One drawing could be used. Yes, one drawing. So again, esophagus, look, esophagus like that, and then again the opening into the stomach. No, this is not correct. That must be a little bit different, like that. Okay. So on one side we can draw veins. Why not veins? Okay, one veins, fine. If we have the stomach, we are drawing the stomach, and this must be really a little bit changed. Stomach, and then duodenum, like that. This is too wide. It could be. Here we have also the spleen with the hilus, and on this side we are drawing the veins, on that the arteries. So concerning the veins, the fact is that here there is a plexus which is drained into the azygos system, right? Mainly into the azygos veins. Of course, it means also hemiazygos, etc. And they open into the inferior, not inferior, with connection to inferior, but opening into the superior vena cava. Superior vena cava. This is true. So they open finally in the superior vena cava. Again, repeating, on the left side are the veins, on the right side are the arteries. So, but at the level of the cardia, because this is cardia, right? Cardia of the stomach. There are also the other veins. We could use a violet color. Here we have the portal vein, repeating the word portal vein. This is that one. Portal vein, which collects the blood from unpaired organs of the abdominal cavity. They are the vessels that communicate. These are the short gastric vessels. They open into portal vein. Then there is also, there are gastric veins from the lower part, also from gaster, but also from the area which belongs to the gastric veins. I will label it gastric veins, right and left. These ones are the, this is cardia, the place here, and these ones are short gastric veins. No, I can add short gastric, but gastric, all of them open into the portal vein. So portal vein and vein belonging to the systemic vein, superior vena cava. And here at this level, arrow, which red, like red, at this level in cardia, putting red point, which indicates that there is the place of the, we call it portocaval or portosystemic anastomosis, which means that in case of the blockage, in case of blockage of flow of blood, blockage of flow of blood through the liver, so blockage in the liver circulation, usually cirrhotic liver. So in such a case, because there is a higher pressure, there is this situation can lead to the enlarged submucosal veins, venous plexuses, which are fragile, because you see the vessel has one defined thickness of the wall, and the veins are very thin. So even enlarged submucosal venous plexuses may cause the fragility. So fragile venous plexuses, which can lead to bleeding. This is called mucosal bleeding. Sometimes the patients will come vomiting blood, right? And the bleeding from the varices, we call them venous varices, leading to bleeding of venous blood. No, so it's of high clinical importance of such a connection. Importance, correct, clear, and done. No, so we fully understand that here there is important interconnection. No, concerning the arteries, it's very easy. The arteries come from aorta usually, so we would put directly from aorta, then from we call it bronchial, aorta, esophageal branches, but also bronchial arches, because bronchial arches are many. So then some of them also supply also aortic branches. Then intercostal also, some of them are intercostal arteries, branches, maybe branches also. And finally, one comes from phrenic artery, superior phrenic artery. No? So we describe the blood supply, venous drainage, lymphatic drainage, innervation. Last note, concerning the we already mentioned the blood, we haven't mentioned lymphatic drainage. Okay, lymphatic drainage, just the names, because you already defined all the lymphatic systems of the thorax in the lecture Monday. So lymph is drained into there are more, because you see esophagus is long, it's 28 centimeters long, so must be lymph nodes. They are deep cervical. I'm not sure if I already did it. Yeah, we did it. Sorry, already done in one diagram. This is done. So finalizing the text concerning the topographic relations. So just shortly, relations of the esophagus. Very briefly, esophagus. Topographic relations of esophagus. Yes. So cervical part. The most important would be anteriorly trachea. Yes, anterior trachea, and plus on sides recurrent nerve, recurrent laryngeal nerve. This is what we said a million times. Then posteriorly, we would underline by yellow. Anterior, posteriorly must be considered the vertebral column. Yes, because it's in close proximity to vertebral cervical column. Yes, cervical part, correct. Then follows the thoracic part. Anteriorly again. Left bronchus, we said that there is this place of the constriction, left bronchus, of course, left principal bronchus, definitely. Trachea, then pericardium, anteriorly pericardium. What else? Pericardium, left vagus. Left vagus, sufficient. Posteriorly, vertebral column, thoracic duct. This is important. Thoracic duct plus vertebrae. sufficient thoracic duct vertebrae. What else? Vagus, yes, and aorta, because aorta changes the position. On sides, again, the aortic arch, thoracic duct, etc. I mean that this is good. Left, yes, but we have to mention left side. What is on the left side? On the left side of esophagus. Sorry. I will just stop it. Obejde ještě 15 minut přednášku. Left side, aortic arch of aorta, just one thing, and right side is the azygos vein. That's it, azygos vein, sufficient. And finally, the abdominal, very short abdominal part. This is very easy because in the abdominal portion, what we see, this is around 1 and 2 centimeters. We just see the abdominal part. Just this is what we have mentioned in one previous drawing. You see, this was that one, what we said in the diagram, what we see. So then maybe just the components, I would say components helping or assisting, maybe assisting in closure, assisting in closure of the I will just put sphincter. It's not sphincter, but I would say this would be like the sphincter. Yeah, or sphincter. This is not sphincter, not true sphincter, but I mean this like that. Sphincter, okay? Better. Sphinx. Last words must be good and clear. Sphincter, right? With apostrophe, and it's not sphincter. Fine. No, so I mean that we said everything concerning the topographic relations. Sorry, I have to roll up and then finishing, completing. So I mean that we did the best. We completed always completed the chapter topographic anatomy, review of the topographic regions. Always is the problem in such a relatively short time, although for lectures more than sufficient to complete everything. Say some words for the typical characteristic data of all structures or description of each organ, and also to describe the course of the organ and mention all the topographical relations. This is really not easy, but I hope that the thorax was not so complicated. We did the best. Thank you for your attention, and see you again listen or looking at the next week when we will start with the abdomen, right? So this will be abdominal cavity. Topography of abdomen also will follow. Thank you for attention. Good afternoon. Bye bye.